good afternoon to everyone. So it's been great pleasure to be a speaker at the National Conference RSSDI Kerala. So today my topic is a cardiac energy metabolism shift in diabetic cardiomyopathy and then heart failure. So these are all the flow of my discussion. The epidemiological relationship between the diabetes and heart failure and pathophysiological mechanism and differentiating the diabetic cardiomyopathy from other causes of the heart failure and outline the management strategies emphasizing the cardiorenal metabolic production. So as Sir briefed about the epidemiology, in diabetes, 2 to 5-fold higher risk of developing the heart failure. The heart failure prevalence in diabetes is 30%, whereas in general population is only 6%. This shows the how higher risk development of the heart failure among the type 2 diabetic patient. The hospitalized heart failure patient, among which is 40 to 45% were diabetic. The heart failure in diabetes, the progression, because it will increases the morbidity and readmission, that will decreases the quality of life. The diabetes, heart failure and renal dysfunction form the vicious cycle. I just want to brief the basics of energy metabolism in the normal heart. So here you can see in the heart, the ketone body oxidation is only 15%, whereas the branched chain amino acid oxidation is 3%, fatty acid oxidation is 40 to 60%, and the glycolysis is 8%, and lactate is 15%. And here, at the end, all this metabolism helps to formation of the acetyl-CoA. That way, it will enters in the TCA cycle, and further it enters in the electron transport chain for the formation of the ATP. This is the main energy source for the cardiac health for normal functioning. So the same thing, the ATP turnover from the mitochondria, 95% from oxidative phosphorylation and 10% from glycolytic pathway. The fuel utilization, this is the main thing, 70% of the fuel utilization from fatty acid and 30% from the glucose, and small contribution from the ketone bodies and then amino acid. The metabolic flexibility, so always the cardiac muscles will utilize the glucose, whereas in case of the diabetes there is an increased insulin resistance, there will be a shift from the glucose utilization to the fatty acid oxidation. And fatty acid metabolism enters the beta oxidation, acetyl-CoA for the development of the ATP. This is the basic thing. So the diabetes and the heart failure. Why we need to discuss about the heart failure and diabetes? What is the significance? Because the incidence is increasing with the age, and also there will be a 30% development of the heart failure among the diabetic patient. This is very huge risk. And the mortality of the diabetic heart failure is double than that of the non-diabetics. So our basic idea is to prevent the development of the diabetes, and also if already a diabetic patient, we need to keep it under control to reduce the formation of the heart failure. So here you can see the numbers. Only 1% increase in the HbA1c level, it will put prone for 16% increase risk of the heart failure. So the importance of reduction of the HbA1c in the periodic checkup, it will help you to prevent the heart failure. See, only 1% reduction, it will reduce the 16% risk of the heart failure. So pathophysiology, in the diabetic heart failure and cardiomyopathy, the main mechanism is shifting of the glucose metabolism to the fatty acid because of the insulin resistance. So thereby the efficiency of the cardiac function will get reduced, thereby the mitochondrial dysfunction and then the free oxidative damages further the heart failure. These things. The metabolic shift, the increased free fatty acid oxidation thereby reduces the glucose utilization, thereby reduces the efficiency. So the end product, the increased fatty acid form the fat accumulation in the myocytes, thereby it ends up in the apoptosis and then the fibrosis. And further oxidative stress and advanced glycation end products further damages the cardiac muscles, and then fibrosis, stiff heart and diastolic dysfunction. Most of the time in our clinic practice, we used to send the diabetic patient for the screening echocardiogram. It will give a report as the diastolic dysfunction. So what will think the patient as, doctor, is there any problem with my heart muscles or heart cells? We will say diastolic dysfunction. We always concentrate on a systolic dysfunction. The systolic function may be normal. The diastolic function slowly worsening the heart. We need to give importance for the diastolic dysfunction. So then the mitochondrial dysfunction in the cardiomyopathy results in the insulin resistance and then a decreased energy efficiency, inflammation and fibrosis of the cardiac myocytes, and progressive cardiac dysfunction. So these are all the ominous update of the heart failure in diabetes. In diabetes, not only the heart failure, so many cardiac pathology like coronary artery disease, myopathy, microangiopathy, and hypertension. So many heart failure risk factors there. So if you closely observe this slide, the pathological mechanism involved in the development of the cardiac myopathy. So here the type 2 diabetes and then obesity, there is a cardiac insulin resistance. Thereby again the mitochondrial dysfunction, impaired calcium handling, and then cardiac stiffness and hypertrophy it forms. The main thing is the altered fuel preference. So mostly for glucose utilization, the energy consumption is very less. Whereas in the fatty acid oxidation, the energy consumption is more and also the production is also less. Thereby lead to the cardiac dysfunction. So if you see, the first is the normal heart and second is the diabetic cardiomyopathy, the metabolic inflexibility. So decreased glucose utilization, increased free fatty acid oxidation, thereby end results is the cardiac muscle contraction will be poor, and then because of the inflammation, the more fibrous tissue formation and the left ventricular hypertrophy. So again the same thing, the stages of the heart failure. The first stage is the subclinical diastolic dysfunction, left ventricular hypertrophy, and later only the systolic dysfunction. The early sign is the diastolic dysfunction. We need to pick up at the diastolic dysfunction itself. And then histological changes like myocyte hypertrophy, interstitial fibrosis, and then mitochondrial swelling. So types of the heart failure in diabetes: preserved ejection fraction and reduced ejection fraction. Preserved is nothing but stiff myocardium, fibrosis, concentric LVF. It's very common in obesity, diabetes and elderly patient. Whereas reduced ejection fraction is the ischemic injury common in coronary artery disease patient and post-MI. The heart failure, what is the definition? A clinical syndrome of decreased cardiac output and elevated filling pressure that leads to the fatigue, congestion. In cardiomyopathy, the name itself is myopathy, muscle dysfunction. It's a myocardium associated with the mechanical and electrical dysfunction. It's more common in a ischemic patient and hypertensive patient. So in cardiac myopathy, main pathology is the muscle. The coronary vessels will be normal. The biomarkers is the NT-proBNP and troponin. Diabetic cardiomyopathy and special subset. Here you can see is the independent of the ischemia and hypertension. As I previously discussed, myopathy is muscle dysfunction, not because of the coronary vessels. And it will lead in the insulin resistance. So because of the insulin resistance, the glucose cannot able to enter into the myocytes. So it will shift into the free fatty acid oxidation, and then advanced glycation end products results is form the fibrosis and microvascular dysfunction, and will result in the impact coronary perfusion, at last end up with the preserved heart failure. Later it will develop into the reduced heart failure. This is a simple slide. If you see the cardiac myocyte, the glucose utilization is impaired because of the insulin resistance. The lipids accumulated more, intake is more, and free fatty acid oxidation is more. Thereby it end up into the inflammation, fibrosis, and reduced ATP production. So the key metabolic disturbances and associated consequences in the diabetic cardiomyopathy. If you see at the outer cell surface, the CD36 is increased. Thereby it will increases the free fatty acid intake and free fatty acid oxidation. It will results in the further reduced efficiency of the cardiac contraction. The GLUT4 cell decreased receptors, thereby intake glucose uptake will be reduced, and decreased glycolysis, decreased glucose oxidation. So where we can target for the management? Here the therapeutic strategies targeting the cardiac metabolism in heart failure and diabetic cardiomyopathy. We need to enhance the glucose utilization by the AMPK activators, like it will increases the glucose uptake and increases the glycolysis, and modulating the free fatty acid metabolism. CPT1 inhibitors that will shift from free fatty acid to glucose oxidation, and PPAR modulators that will regulate the free fatty acid uptake and oxidation. We need to target the ketone pathways like SGLT2 inhibitors. It will increase the circulating ketone bodies and promote the cardiac ketone body utilization. And reducing the lipotoxicity, as we saw earlier, the free fatty acid intake is more and then fatty acid oxidation more. We need to reduce the lipotoxicity. Ceramide synthase inhibitors and antioxidant mitochondrial protective agents. So how we can manage this patient, diabetic patient? So first we need to consider on the control of the glycemic level, the glycemic control. We need to avoid the agents that will worsen the heart failure like thiazolidinediones, and we need to prefer the SGLT2 inhibitors like empagliflozin and dapagliflozin. Nowadays, instead of the like a physician, more of the cardiologist using the empagliflozin and dapagliflozin for the heart failure management, prevention. For heart failure therapy, the AC inhibitors, ARB, and then ARNI, and beta blockers, mineralocorticoid receptor antagonists like aldactone, eplerenone, and loop diuretics for relief of the congestion. Additionally, we need to consider for control of the blood pressure, lipid, weight management, and we need to manage the renal function. So, for overall, we need to control the glycemic levels. So, role of SGLT2 inhibitors in the diabetic cardiomyopathy, how it will help to prevent the progression of the heart failure. If you see, the SGLT2 inhibitors improve the cardiac metabolism in DCM and will improve the mitochondrial function. It will inhibit the ketone body metabolism and then oxidation. How you see here, the SGLT2 inhibitors, the expected molecular level mechanism of the effect of the SGLT2 inhibitors on cardiomyocyte dysfunction. So, role of SGLT2 inhibitors in the heart failure. It will reduces the heart failure hospitalization by 30 to 35% of the diabetic patient, and benefits is independent of the HbA1c level reduction. How it will work, because it will reduces the preload and afterload, thereby it reduces the fibrosis and mitochondrial efficiency. The Braun will describe them as the first anti-diabetic class proven to prevent the heart failure. So that's how the SGLT2 inhibitors is more important to prevent the heart failure development. So my last slide, take home message. The healthy heart is metabolically flexible because it primarily using the fatty acid and glucose for ATP. In diabetic cardiomyopathy and heart failure, this flexibility is get lost because reduced glucose uptake and oxidation, increased reliance on the fatty acid oxidation, so thereby inefficient and increased oxygen consumption and lipotoxicity, and increased ketone body utilization as an adaptive energy source. All these mechanisms leads to the imbalance and end up in the mitochondrial dysfunction, development of reactive oxygen species, and contractile impairment. The restoring this metabolic flexibility by balancing the glucose, fatty acid, ketone is the key preserving the heart function. So the same thing. So thank you. We need to concentrate on the glycemic control, and we need to prefer the SGLT2 inhibitors for the prevent the progression of the heart failure. Thank you so much.
Thank you for an excellent talk, madam. Rather than asking you a question, I'll just summarize, because this is a very novel concept in the management of heart failure. That is cardiac energy metabolism shift. If you have gone through her slides, you would have wondered, we studied in our undergraduate classes that heart uses fatty acids as the main source of energy rather than glucose. But now we are discussing why there is a decreased glucose and increased free fatty acids. But the concept is entirely different, because normally the heart uses around 60 to 90% of the energy for the heart is from free fatty acids, and 10 to 40% is from glucose. So here what happens is that both of these produce ATP, but how energy efficient that is the main concept. So if you look at the glucose pathway, or to generate around 31 ATPs, you require at least 6 oxygen molecules. But on the other hand, if you use free fatty acids for generating ATP, you can generate around 103 ATP at the expense of 23 oxygen molecules. So there is something called oxygen phosphate ratio. So if you look at that, this ketone body pathway or free fatty acid pathway is a less energy efficient pathway. So if the heart predominantly goes through a less energy efficient pathway, that results in gradual decline of function in heart failure. That is the overall concept of cardiac energy metabolism shift. And the overall concept of treatment is based on how to reverse it. And there is, if you go by increased free fatty acid metabolism, there is increased free oxygen radical formation, then mitochondrial dysfunction. Ultimately, that results in heart failure. This is more in the micromolecular level. And regarding the treatment part, Again, the focus is upon SGLT2 inhibitors, GLP-1 agonists, and one drug which you may not think of in heart failure, that is pioglitazones. That is, even though we don't recommend it in heart failure with reduced ejection fraction, the initial phases, if you can reverse the insulin resistance in the phase of heart failure with preserved ejection fraction, you can prevent heart failure. So this is the overall concept of all the talk. Thank you so much, madam.
We will take the questions at the end of the session.